Hello, I'm Dr. Richard Larson from the University of Chicago, and I'm here in Barcelona at the International Workshop on Acute Leukemia with two of my colleagues.
Yes, my name is Christoph Röllig. I'm working as a consultant hematologist at the University in Dresden, Germany.
I am Adriano Venditti, and I am an associate professor at University Tor Vergata in Rome, Italy.
And earlier this morning, we've been discussing acute myeloid leukemia, some of the clinically important decisions that are made around risk assessment, as well as the use of some novel agents, both in older patients as well as in maintenance therapy. So I think I'll ask Dr. Röllig first to tell us about what we know on the use of maintenance therapy in AML.
Yeah, so I try to kind of summarize the evidence that we have so far coming from a historical perspective that maintenance has been part of a regular treatment at the beginning of acute leukemia treatment from the 60s on. However, that maintenance with the conventional cytotoxic agents that we know has not been very effective. It could maximum replace an intensive conditioning treatment, but beyond that had no effect. I was kind of reviewing attempts to kind of use other drugs such as interleukins to obtain better results with maintenance treatments. Those agents like interleukin and interferons didn't work very well either. And then I focused on targeted agents that are upcoming and that are now shaking up or moving the treatment area in AML. And I try to show the candidates from all the different classes of targeted agents that are active or that have been evaluated in or are ongoing clinical trials, and try to show for which of those agents we have randomized evidence. And it's only very few of them that have randomized evidence, and I kind of try to sum it up and draw conclusions or kind of pose questions on how to go ahead with maintenance treatment.
So we know that acute myeloid leukemia can be polyclonal with a number of subclones. We had a lot of discussion this morning about that. How likely is it that a targeted therapy used in the maintenance setting is going to be able to cover the whole landscape of multiple subclones?
Well, obviously, based on what you just said, it would be best to have an agent that is that is covering more than one target if possible. So maybe like when it comes to tyrosine kinase inhibitors, for instance, maybe less selective tyrosine kinase inhibitor could be more effective than more targeted ones. However, we don't know yet, since we have some encouraging results post-allo with first generation TKIs, midostaurin and sorafenib, but there are results that we still wait for from randomized trials for more with more specific TKIs such as gilteritinib. And then on the other hand, I think there is still hope that less specific targeted agents such as hypomethylating agents or maybe hedgehog inhibitors or other more broad working agents could improve results more than, could have a good effect on outcomes.
So we've heard a little bit about immunotherapy. Do you think that the bispecific tumor-engaging molecules like the development of the anti-CD123 and CD3 molecules will have a role to play in maintenance therapy?
At least the data we've seen are still preliminary with small patient numbers and mainly focusing on feasibility and dose finding. However, if we look at ALL treatment landscape, it seems that bispecific antibodies or monoclonal antibodies are best when it comes to eradicating MRD, and that they work best when the tumor burden is low. So if that should be the case in AML too, then the immunotherapies may have their best position in that area.
Very good. Professor Venditti, can you tell us something about the Jemima trials, your recent results, and your group's evaluation of risk assessment and MRD?
Yes, well, the idea behind the Jemima trial, the Jemima protocol, is to refine risk stratification of patients with AML, risk stratification conventionally based on genetic and cytogenetic features. Well, refined this approach by incorporating MRD evaluation. And we believe that this MRD evaluation may help physicians optimizing therapy, especially the post-induction therapy. For instance, making a more proper decision about the use of allogenic stem cell transplant or alternative approaches such as autologous or intensive chemo. And well, that is what we did in our protocol. And what we found was that especially for the intermediate category, for whom the post-consolidation therapy was MRD driven, well, we found that this category had a duration of overall survival and disease-free survival that was superimposable to the one of low-risk category.
And what technique are you using to measure MRD? Is it leukemia-associated immunophenotype or PCR or some combination?
In the protocol, we used a flow cytometry-based approach. Actually, we used an 8-color assay, and but of course, we know that there are some specific molecular markers that can be tracked by using PCR, and probably this approach in these selected cases will be more sensitive than the flow approach.
So in my presentation, I was asked to review the landscape of the treatment and outcomes for older patients with AML. And this is an area that's rapidly changing as some of the new agents that have already been approved for relapsed refractory disease are making their way into frontline use, either as single agents or in combinations. So we've known for many years that AML is mostly a disease of older individuals. The median age is in the range of 70 years old, and yet these patients often have not been included in frontline chemotherapy trials using intensive treatment. However, there are some data that even for patients in their 80s, if they can tolerate intensive chemotherapy, they can get a clinically useful benefit and prolonged survival. So I tried to emphasize that age alone is not a determinant of whether a patient should be treated for AML, but rather a surrogate for their medical fitness or alternatively their frailness in terms of being able to tolerate the treatment. But as we've already heard, cytogenetic features and molecular changes within the leukemic cells also dictate the response to treatment. And I think that's where some of the newer drugs may have their greatest impact. That is, being able to cytoreduce patients, older patients, achieve a complete remission with less toxicity than we've typically experienced with cytarabine and anthracycline regimens. Once patients are in remission, of course, additional treatments required to cure AML, and there the controversy for those patients who are eligible for an allogeneic transplant is whether they should undergo an allogeneic transplant with a matched donor or whether they should continue on conventional chemotherapy. And some recent data for patients between the ages of 60 and 77 suggests that at 1 year, the survival is equivalent between those two groups, between conventional chemotherapy and an allogeneic transplant. But beyond that point, patients who have survived and engrafted well with an allogeneic transplant do seem to have a survival advantage. And this result is most clear, I think, in those patients with an adverse karyotype. So for patients over the age of 60 who are healthy enough to tolerate an allogeneic transplant in first remission, the recommendation is generally to proceed with an allogeneic transplant if they have an adverse karyotype, but that conventional chemotherapy for consolidation treatment might be sufficient for those with a favorable or intermediate karyotype. So we're looking forward to hearing more later this afternoon about some of the other novel developments in acute myeloid leukemia.